So I welcome everybody to the English webinar, which is going to be starting right now. We're going to talk about an update on urticaria, talk a little bit on causes, triggers, and most of all about the therapy of urticaria and what has been changed and what is new, and what has happened actually the last year since the last webinar due to Urticaria Day. So as you all know, I guess you are people experiencing urticaria, either having urticaria or knowing people with urticaria. Urticaria is a disease which is characterized by the appearance of wheals on the skin. Wheals actually look like nettles, nettle stings, which you probably all remember from your childhood. But it's not only the nettles or wheals on the skin, it could be also so-called angioedemas, swellings of the lips, of the eyes, of the tongue, which also belongs to the disease, which also belongs to urticaria. And the most important thing is here that there's a lot of people, they're actually suffering from both, having wheals and angioedema, but there's also some patients only having angioedema. There's other causes which may trigger the appearance of an angioedema, like hereditary angioedema, for example, a very infrequent heritage disease. But having only angioedema could also be a form of chronic urticaria. You see, this is how it looks. Even in your face, you could have wheals, but basically you could have the wheals all over your body, and you could even have the swellings all over your face. Sometimes it may also involve your hands or your feet. Urticaria is a disease that actually may affect from the very young to the very old, and it is a frequent disease. So there is actually people experiencing a urticarial rash, which is 1 out of 4 or 1 out of 5 at least, which we call an acute urticaria. An acute urticaria, however, is very self-limiting. So it's by definition doesn't last longer than 6 weeks. So it is actually not a big problem in treatment. Which is a problem in treatment is chronic urticaria, which lasts longer than 6 weeks and which lasts much longer than 6 weeks. Most patients suffering from chronic urticaria have this even for years. But fortunately, the transmission from acute to chronic is not frequent. It's about, let's say, 1 to 2% of people experiencing an acute effect that actually keep the disease and having chronic urticaria afterwards. Chronic urticaria could actually be an aesthetic disease, at least if you look at the left picture. This is a special form of urticaria which is called urticaria factitia in German, symptomatic dermocratism, we say, where the wheals actually appear by a physical stimulus on the skin, and this girl actually were able to even draw pictures on their skin, but she also suffers from angioedema, which is of course not a very aesthetic scene. Men are not the only that are affected by urticaria. Even animals, especially horses and dogs, could have urticaria as well. And what actually happens in the skin when we have urticaria, when a wheal is developing? Well, you see a wheal here on the picture, and what happens actually underneath the skin? You see the wheal, you see an erythema which is around the wheal. So well, this happens all because all of us, not only urticaria patients, all of us have a special cell type in the skin which is called the mast cell or the allergy cell. We not only have this cell in the skin, we also have it in our gastrointestinal tract, in our lungs, in our airways. But in urticaria, this cell actually gets stimulated and activated. And if this happens, the cell releases a whole bunch of mediators and most important histamine and others. And the histamine released actually have different actions. So it activates itself sensory nerves. That's why the wheal is itchy. and it stimulates blood vessels, make them dilate and make them being leaky. And that's the reason why the skin gets red and why a wheal is developing. A wheal is basically nothing else than water coming from the blood into the tissue. This is a wheal or an angioedema when it comes to the face. So as said, histamine is an important mediator in urticaria, but it's not the only mediator in urticaria which is important for the disease. As we know, there is, for example, prostaglandins, leukotrienes, PAF, which all has been shown to also be involved in the elicitation of symptoms in chronic urticaria. But what could actually be the triggers? So we know there's different forms. There's chronic spontaneous urticaria where the wheals just come and people don't know what is the trigger that causes the wheals in that moment. But there's also other triggers. There's a group of inducible urticarias where, for example, cold, sunlight, friction, pressure could be a trigger. And in those forms of urticaria, the wheals only come when this trigger is present. So the wheals only come when the skin gets in contact to cold, for example. They come never spontaneously. This is how those two forms, or let's say groups, of urticaria are distinguished. But there is mixed forms. There is actually people that could suffer from both. They could have chronic spontaneous urticaria, and additionally, they may also react to cold, for example, or to friction, symptomatic dermographism, which is the most frequent associated inducible form of urticaria, together with chronic spontaneous urticaria. So let's come to spontaneous urticaria, because this is where treatment and impairment of quality of life is most relevant, because you never know when the wheals come, when the angioedema starts. And over the last, let's say, 10 to 20 years, a lot of different ideas what may cause the urticaria actually in a patient may be relevant. And there has been different things described. There's infections, there's intolerance reactions, there's something which is called autoreactivity, which may be a cause of having chronic urticaria. And let's go a little bit deeper into those different causes. Let's talk about infections first. So there is actually observations only that chronic infections, for example, in the ENT area, in the teeth, or a bacterial colonization of your stomach with a germ which is called Helicobacter pylori, may be associated with urticaria, because people having urticaria have been investigated for such chronic infections, and they were found. They were found a little bit more frequent than in people not having the disease. And most important, people have also observed when you treat the infection, then urticaria is likely to go away. But there is no proof, because urticaria itself is a disease which has a very, very high tendency to disappear itself. So urticaria ever is a self-limiting disease, but it could last for years. So therefore, the scientific connection between those underlying infections and chronic urticaria is not really sure. Let's come to autoreactivity. Autoreactivity is interesting because there is a group of patients having chronic spontaneous urticaria in which you can find specific autoreactive antibodies. Actually, the same antibodies, or very similar antibodies, you have if you are allergic. If you are, for example, allergic against birch pollen or foods, you have specific antibodies that are directed against birch pollen or against food, and this is the antibody sitting on the surface of the mast cell, and if the birch pollen comes, then the mast cell gets activated. In chronic urticaria, you find actually antibodies that are either directed against those receptors where the allergy antibodies usually sit. So by this antibodies, the mast cell could be directly activated to release histamine and to cause wheals and angioedema. And there's one simple test how you could actually test yourself, or actually being tested by your doctor, if you have autoreactivity, or if your urticaria could be due to autoreactivity. The simple test is called the autologous serum skin test. What is being done is that you actually you take the patient's blood, or the patient's blood is drawn, is spinned down so that all cells, or the red color goes away. We only have the serum, the blood serum, and with this blood serum you can do an allergy test, simple intracutaneous test. So it gets injected into the skin. Histamine as a positive control and saline as a negative control. And about 1/3 of the urticaria patients react to their own serum. What does that mean? It means that in the blood, at least of 1/3 of urticaria patients, there is something which is able to activate the mast cell and to leave the mast cell release the histamine, causing wheals and angioedema. But what is it? Well, it might be that it is the autoreactive antibodies directed against the mast cell receptors, but it could be something else, because the number of patients being autoreactive in that skin test is way higher than the people in which blood you can find these specific antibodies. So last but not least, autointolerance or intolerance reactions are being discussed. So intolerance reactions to either drugs or to food. And the intolerance reactions to food, it is very important to distinguish here between food intolerance and food allergy. So if you are allergic, for example, to nuts, which mostly starts in your childhood, most of people allergic to nuts, they know. They know whenever they got in contact to nuts or even eat nuts, minutes later they got their reactions and they have their allergic response. Wheals and angioedema could be a symptom of this allergic response, but this is not what we mean by the disease chronic spontaneous urticaria. Food intolerance in chronic spontaneous urticaria is different. It is not the usual foods to which you have allergy antibodies, and the reaction comes not immediately after minutes. It even takes days, at least hours, until the reaction starts, until you start getting wheals, or the intensity of your urticaria is getting much more intense. And it's dependent on the amount of a specific food. So the problem with those food intolerance reactions in urticaria is that there's actually no good test. There's no skin test, there's no blood test, which would give us an answer to which foods you are intolerant and which foods may cause your urticaria. This is a problem. So what is actually being done is that people are recommended to do specific elimination diets, because it's basically food additives which may cause these food intolerance reactions. It is not simple, but it could be done to eliminate those additives from your diet for a specific while. We recommend to do this for at least 3 to better 4 weeks, and to observe what happens to the intensity, the frequency, the number of wheals, the intensity of itch, and by this actually try to find out, is the food a relevant component to your disease. So by doing this, is actually very important to do it for a long time. In this graph here on the right side, you see a blue line and you see a red line. And of course there is people doing the diet, they do not respond, meaning their urticaria is not getting better. But in some people the urticaria is getting better. And this is German here, I apologize, but on the lower you see actually days, the number of days. And you see until your urticaria is starting getting better compared to your baseline where you start, it actually takes at least 2 weeks, at least 3 weeks until you really see and can measure that the urticaria is getting better. So this is a very important thing here, but this is very difficult to do, and you should have someone who is guide you in doing a diet. Don't do this alone, because there's many bottlenecks here. You need advice to which foods you should avoid. So here in our clinic, we do this by giving our patients a diary and actually a receipt. So they got strict guidance how to cook. And we feel this is the best and most promising way. But even if you get a list with having foods that should be avoided, those lists are never complete. So there will always come questions. Can I eat this? Can I not eat this? So in doubt, you should better not eat. But don't make yourself crazy. Please go to someone, ask who's experienced in doing those diets. If you are interested, or if you feel I have to test if food is a relevant trigger for my disease. So, but is it actually true that all those triggers are relevant causes for urticaria? There's still some at 30%, 1/3, where no trigger is found. And over the last years, we actually keeping asking ourselves, what is it really? How could intolerance reactions cause urticaria? How could infections cause urticaria? It's not so easy to answer, because it's actually not known how bacteria in your stomach could activate the mast cells in your skin. And we have learned a lot of recent therapies being done in urticaria, and we actually believe right now that all those triggers are relevant, but probably they are not directly involved, or not directly activating the mast cell. There must be something in between. And what is in between? Well, what we know by now is that what is true for autoreactivity, there's much more antibodies which we can now find in the blood of urticaria patients than we earlier thought. There's a lot of allergy antibodies, the same antibodies you have again against birch pollen or foods, for example, but this is allergy antibodies directed to structures in your body. So that could even be your own tissue, something in your skin, or it could be bacteria that are relevant for the infection you have. That could be drugs, that could be food. And those antibodies are more and more frequently found in urticaria patients, and we believe that this might be the missing link. Because, why do we believe this? Well, you all have probably heard that there's, since a couple of years now, 3 years to be accurate, there's a new treatment for urticaria, which is anti-IgE. So anti-IgE, Omalizumab, is tremendously effective in all forms of chronic urticaria, not only in the autoreactive ones, even in the patients that do not show autoreactivity. And by blocking those IgE antibodies, it was the big question, how could be a urticaria be treated very effectively by a drug blocking the effects of allergy antibodies in urticaria, in which we believe that chronic infections are the relevant trigger. Well, this might be the missing link. Let's go into therapy and really talk a little bit more about therapy. There's one big goal we have, and the goal is bring the urticaria under control. We want our patients to be off symptoms completely. And how are we going to do this? Well, first look at things that are not effective. Right? There's a lot of ideas out there how urticaria should be treated. But please don't do this. Onions, quark packs, even cortisone creams or ointments, they doesn't help. Urticaria come from the inside of your body, right? There's an internal trigger which causes mast cell degranulation, which causes the wheals. If the wheel is there, no cortisone cream could prevent the activation of mast cells and the action of histamine in the skin. And actually the effect of cortisone just takes too long to block this effect, and it's just not effective. As well as anti-allergic creams or gels. You need to treat the urticaria from the inside, where actually the mediators of mast cells are released. And you probably have heard that your doctors have guidelines available. So there is treatment guidelines how urticaria should be treated. And the first and most important step is, yes, we still treat urticaria in the first step by using antihistamines, an anti-allergic drug. The same drug that people take, they are suffering from hay fever, for example. Important to mention here is that there's different antihistamines. We come to this later, and it should be modern ones, because the modern ones have way less side effects. The old ones, they make you tired, they make you dizzy. Sorry, you shouldn't use them. But let's see how effective this is. So here it comes basically. There's different antihistamines, first and second generation. The second generation is the ones that should be used in modern treatment. Why? Well, there's studies out there actually looking on what happens if you take a first generation antihistamine that make you tired. And there's driving tests being done. So people have taken first generation antihistamines and then were asked actually to follow a car which is driving in front of them. And then they counted the driving mistakes. So how often you will go left or right instead of just going straight. And you see here, for example, diphenhydramine, which is a first generation antihistamine, makes you to have way more driving errors than compared to a modern antihistamine, for example here, fexofenadine. And the most interesting thing is they also put people in the car on a controlled condition that drank alcohol, approximately to 1 per ml of their blood, and you see that the first generation antihistamine makes it even worse than having alcohol in your blood. So please don't take these first generation antihistamines. It's almost being able to say it's dangerous to do so, right? Because you need to take the drug every day. And why is that actually? Well, those first generation antihistamines, they are different drugs, right? They are lipophilic. They go into your brain. And first is they block histamine receptors in your brain, which causes dizziness and drowsiness itself. And there's something else. Those drugs interfere with your sleeping phases, right? You have probably heard about those REM sleeping phases, which you need to feel awake the next day. Taking a first generation antihistamine messes this up, and as a result you feel drowsy, tired, unfit next day. Even so, if you take the antihistamine in the evening the day before, you will have this hangover over the complete next day. So this makes these drugs complicated. Therefore, please only use the modern ones. But if you use that antihistamine in a standard dose, which is 1 tablet a day, well, if you look over a number of urticaria patients, you see about half are sufficiently treated. Only half are sufficiently treated by taking a single dose of antihistamine. So we need to do something else, and the next step of treatment is give more antihistamine. It is actually not in the license, but there's enough studies out there showing that it is more effective and as safe as taking 1 tablet when you take 4 tablets, up to 4 tablets a day. So this can be done with the modern ones, not with the old ones. And please ask your doctor or by yourself to take more of the antihistamine, up to 4 tablets a day. Split it in 2 doses, 2 in the morning, 2 in the evening. Well, if we do this and again look over urticaria patients, how effective we are by this treatment option? Well, it's a little better, but still there's at least 1/3 of patients suffering from chronic urticaria that are not symptom-free even by taking 4 tablets antihistamines a day. And here comes other ideas, but what is not a good idea is actually to take different antihistamines at once. So the combination of 1 or 2 antihistamines is not better than taking a single antihistamine 4 times a day, right? So this is still being done, but at least this study here shows that it's not better. So the antihistamines actually do not more by combining them. So what is the next step? The next step basically is to add other drugs. Keep the antihistamine but add something more. And there's other drugs being described to be effective in urticaria, cyclosporin A, for example, leukotriene antagonists. Leukotrienes are, remember, the other mediators coming from mast cells that are also relevant. But to be honest, there's not much data out there about the efficacy of those drugs, or for case of cyclosporin A, it's very effective, but it is a drug which causes side effects in all patients. So it's just a matter of time when cyclosporin causes either impaired function of your kidneys or increases your blood pressure. So in very, very difficult and hard to treat patients, it may be okay to use cyclosporin for short term. Short term means a couple of weeks or a couple of months, but it's not a drug that could be taken for years. And remember, many patients have the symptoms for years, so they also need a drug that they can use for years. The same is actually true for cortisone, right? Internal cortisone treatment is also effective in urticaria, but cortisone is not a drug that should be taken for years when there is alternatives, because also cortisone, you know, taking a high dose and over years causes side effects. But the new drug available is Omalizumab. This is the anti-IgE. And let's look what is the anti-IgE, because we have to talk about this, because this is really a magic bullet and have changed the landscape in the treatment of chronic urticaria over the last years. So this drug is not a pill. It's actually an injection which is being injected under the skin like a vaccine. And this is done once a month, every 4 weeks. You're getting 1 shot, actually 2 shots, because you need double the dose. This is the best dose for treatment. But the nice thing is 1 shot every month and 1 month symptom-free. This is what counts to most patients. And there has been, of course, study conducted, which in the end resulted in the license of Omalizumab for the treatment of chronic urticaria. And you see in those studies different doses of the drug were tested, starting from 75 up to 300, and in some studies even more. But it turned out that the 300 milligram is actually the best dose to control the symptoms in chronic urticaria. You see the red line here. This is the patients that were treated with the placebo in those studies. So they also get a little better, but not much. And the green line is the patients that have been treated with the Omalizumab. Every arrow here is an injection every 4 weeks. And you see an interesting phenomenon here, which our boss calls the whoop effect. So you see very close to the next injection, so very close to the end of the 4 weeks, the symptoms already start to get a little bit worse. It's not the case in all patients, but in the mean, it's the case. So what does that mean? It means actually the drug is effective, but in some patients, it doesn't last for the complete 4 weeks. So it is therefore, let me go to this, it is therefore in some cases necessary to individualize this treatment a little bit. So because what can we do? In this cases where we have the whoop effect, it might be okay, or it is basically okay, to shorten the intervals. Not only give the drugs every 4 weeks, just give it every 3 weeks, or if necessary even every 2nd week. That can be done. Same safety profile, because this drug is very, very well tolerated by all patients. There's no severe side effects. There's actually not even any mentioning side effects in this drug. Why? Because it very specifically acts against those allergy antibodies. And what are they good for? Well, they're making us allergic. Yes, no one needs allergies. And it is part of our immune system. That's right. But it is part of our immune system which we, well, let's say, not really need much, at least not nowadays. Right? So IgE antibodies are also involved in the defense to parasite infections, for example. But even in countries where parasite infections are still an issue, like for example India or Malaysia or other Asian countries, the treatment with Omalizumab has not shown any critical increase in parasitic infections. This may be because we are not bring the allergy antibodies or the IgE antibodies to zero, but we're just reducing their activity, reducing their number, so that those antibodies, autoreactive, remember, to our own structures or to the bacteria that colonizing our stomach, for example, just at a level that this cannot cause urticaria, right? But there's also other people that receive 300 milligrams of that drug. Their symptoms get better, but their symptoms are not completely disappear. Well, in this cases, it may be an idea to even increase the dose of that drug. So it is not licensed for urticaria to use a higher dose than 300 milligrams. But we know that a higher dose is as safe for the treatment as the 300 milligrams. Why are we knowing this? Well, Omalizumab is not a new drug. We know Omalizumab for at least 10 years, and it used to be for 10 years a drug for allergic asthma. And the dose which is used to treat allergic asthma is double or even quadruple the dose as we use for urticaria. So we have very good experience in treating patients with this drug in higher doses. So therefore we, from a medical point of view, we have no concerns in giving more from the drug. And this is what is being done, and not many, but some of our patients that even really respond, only if you give them 450 or even 600 milligrams of the drug. Chronic spontaneous urticaria is the disease in which this drug has been tested in the clinical trials that result in the license of the drug for the treatment, but we know it is also effective in the other forms. So in the entire group of the inducible urticaria, for example, symptomatic dermographism or cold urticaria. You see here, this is a patient having the wheals after friction on the skin, and with the anti-IgE, the Omalizumab, you see red stripes still, but there's no itch and there's no wheal. Or even most promising in cold urticaria. This is a test device where we test for cold urticaria. There's different temperatures applied to the skin, and you see here from 4 up to 20 degrees this patient is developing wheals due to cold. And here's an example. You see 22 degrees is the last temperature where this patient developed cold wheals, and with Omalizumab the same patient does not respond to cold anymore. No wheals, no itch. Very effective. And the same is true for solar urticaria. Patient here having wheals by being in the sun, and the same patient being in the sun, no wheals, even after the first injection of Omalizumab. And this is something very special for the drug. More than 80% of patients actually got symptom-free, no wheals anymore, after the very first injection of this drug. So it is really a brilliant thing for those getting not rid of the symptoms by simply taking antihistamine. There's by now even controlled studies being conducted in different forms of chronic inducible urticaria. There's controlled studies for symptomatic dermographism, controlled studies for cold urticaria, studies that are going to be published soon, and there's probably more studies followed by them, so that we all hope that in the next few years we might also get the license to use the drug not only in the chronic spontaneous but also in the chronic inducible forms. So to sum up, urticaria is a frequent disease. It is a very annoying disease. It is disfiguring when you have the angioedema, and therefore all forms of chronic urticaria really result in a tremendously and very, very high impairment of life quality in the patient suffering from the disease. And this is why this is a disease that really needs effective treatment strategies. There is possible causes discussed, as we have learned: infections, food intolerance, autoimmunity, but we have also learned that the autoreactive IgE antibodies, even autoallergic IgE antibodies. There's, for example, patients having IgE antibodies against their own thyroid. So speaking, they're allergic against their thyroid. They are allergic against self. So this is another concept. This fits into this, that we think today that there's people allergic to themselves or allergic to own body structures, or in the sense of infections or intolerance reactions, allergic to food and drug. Not in a way like classical allergy, but those IgE antibodies have their effects in chronic spontaneous urticaria in all forms, because otherwise anti-IgE wouldn't be as effective as it is. So, but the treatment option still, we ever start with an antihistamine, we updose, we give more of the antihistamine if the single dose is not sufficient, and in the cases where this is not effective, we go to modern strategies of treating the disease, and the most effective treatment strategy is the anti-IgE by now. So you know that you have the possibility and opportunity to ask me questions in the chat. I have one question which unfortunately is probably written in Dutch. I'm not actually, unfortunately, not able to read Dutch. So please repeat your question in English. You can write and type your question in the chat box now, and I will be happy to answer them. And here is the first question. So let me start. Okay, so the first question is actually, you talked about the new mast cell activation mechanism, allergy antibodies, and you and your colleagues recently found anti-substances in the blood. When is the publication about this to be expected? This is first part of a long question. So actually the concept has been published already. Our group and other groups have actually reported the phenomenon that there is a higher frequency of autoimmune thyroid disease in chronic urticaria patients. And in these patients, these IgE, those allergic antibodies against their thyroid can be found. We can measure them, and we can degranulate mast cells by using these antibodies and by using the blood of this patient. So this proves the concept of autoallergy. The connection between chronic urticaria and the thyroid was the first condition in which this concept has been proved, but we find more and more different IgE antibodies against self structures. So the thyroid is not the only one. We also find IgE antibodies against DNA, against specific components of the immune system. So there's actually a couple of, for not all of them, a clinical relevance has now been proven. But 5 years back, we were not actually aware that there is autoreactive IgE antibodies at all. So we will learn more about the clinical relevance of these antibodies, but the concept itself, at least in the condition and the connection of chronic urticaria and autoimmune thyroid disease, is already out there. And the second part of the question is about these allergy antibodies as the missing link. How do you explain that omalizumab doesn't work in some cases? Okay, yeah, you're right. The question or the answer to that question is as simple as the question. You have seen that in about 30% of all urticaria patients, we have basically no idea what the cause might be. And there might be even causes out there which are not connected to IgE. And this is not very frequent, because we know that more than 90% of all chronic urticaria patients can be sufficiently treated by anti-IgE. But of course, we are not claiming that all causes and all triggers of chronic spontaneous urticaria are connected to IgE, right? So there might be, of course, other infrequent causes that have a completely different pathomechanistic background, but we wouldn't even know if we wouldn't have now patients that do not respond to the drug, right? But I can't answer, but I can explain why this is or might be the case. And another part, do you think cholinergic urticaria is or can be an autoimmune disease? Well, this is a very interesting question, and I think yes, it could be imagined. Why? We also found or find autoreactive antibodies in cholinergic urticaria patients. We even know that there is a portion of cholinergic urticaria patients that also suffering from other allergic diseases. So this actually distinguishes the cholinergic urticaria patients a little bit from the other forms of chronic urticaria, because only cholinergic urticaria is associated to other allergies, real allergies, which we actually very infrequently see in other forms of chronic urticaria. So the anti-IgE works in most patients with cholinergic urticaria also. Not as many patients have treated with this drug now, but yes, this actually proves that there is a link to IgE in cholinergic urticaria too, as well. But if we also are able to find autoreactive structures, autoreactive antibodies that are, for example, directed against a sweat antigen, or even the sweat glands, we don't know, but we haven't even not intensively looked into this. We are trying, but to detect those autoreactive IgE antibodies is not so simple as it sounds. So actually every new self-directed IgE antibody needs its own assay. So you need to know what you expect, you need to develop a special assay, and then you can detect a new antibody. So it's not to be excluded that we will learn about autoreactivity in cholinergic urticaria also in the next years. So when is the new guideline expected? The new guideline is just about to be updated. There is the International Urticaria Guideline meeting beginning of December, actually 1st of December, here in Berlin. We expect about 200 experts from all over the world to join this consensus meeting, and specific topics of the guideline will be discussed, and probably new consensus will be developed. So we will actually have at least the structure of the new guideline by the end of the year. I believe the publication of the new guideline may be expected in the first quarter of next year. So, I skip some questions because there's many, and this is all from the same person. I may go back to this, but I also have seen there's other people asking questions. And there's one actually, why do I have periods where I don't get any hives for years? Yes, this is a very good question, and this is not so easy to answer. We know that chronic urticaria is in all patients a self-limiting disease. So it goes away in all patients, and it might go away if the relevant trigger or cause goes away. But once having a chronic urticaria, which disappears, doesn't necessarily protect you from experiencing a new or an additional episode of urticaria. You see, no one actually really looked if in an example as you describe, if the urticaria you had some years ago has the same underlying causes and triggers than the urticaria you have years later. It could be a different trigger, but it could also cause urticaria. It might be the same trigger, which disappears for some years. For example, chronic infections, right? Either you get an antibiotic, you cure either on purpose or by chance a chronic infectious trigger, and this might be absent for years, and your urticaria therefore is absent for years. But all chronic infections could be actually re-obtained. So Helicobacter pylori, for example, it might be that there is no Helicobacter in your stomach for years once it has been treated, but of course you can get reinfected, and this reinfection might cause a new episode of the urticaria. I know that in most cases it's not as simple as I describe it right now, but from the mechanistic background and the principle, we think that that could be a reason. So there's another question, and this is actually asked by two people, and I think it's nice to answer this here. So if it is infection of stomach bacteria, would probiotics help? So we have to distinguish between two different things here. If you have the stomach colonization of Helicobacter pylori in your stomach, probiotics may not help because the probiotics are not able to treat the Helicobacter pylori colonization of the stomach. But probiotics may help in another way. We have actually conducted a small study using probiotics in a couple of patients with chronic urticaria, and we have actually seen that in many patients this is effective. We don't know the reason. We could only assume. But you know, there is something which we call the microbiota. So you have a lot of good and bad bacteria in your intestine, on your skin. And it has been shown by many groups, not specifically for urticaria, actually in very different reactions of our immune system, that the composition of this microbiome and microbiota can influence the way how our immune system reacts. So even so, this has not particularly been shown by now that chronic urticaria is influenced, or the tendency to get chronic urticaria is influenced by the composition of bacteria in your stomach or on your skin, probably not, but in your stomach or in your intestine. But it could be. It's actually very likely. So yes, probiotics have been shown to be helpful in some patients, but we don't know the reason and we can't scientifically explain by now. But there's good hypotheses and there is a good way, because the interaction between the microbiota and the immune system are clear, are just not described in all details by now. So is there a link to the leaky gut? I would say yes, probably in terms of the food intolerance reactions, right? Leaky gut is difficult because we don't know what leaky gut or how is the leaky gut, or what is the reason, right? But if you have it, it is likely that more food additives, more histamine and other stuff from food can be get into the circulation and in the system, and this might be a reason why some patients react to food additives with chronic urticaria and others don't. And this brings us actually back to what we have discussed just before this. The microbiota may be involved in causing leaky gut syndrome, but this has not been proven by now. But it's a very exciting interaction, and we actually expect to learn much more about this in the next years. So we have some minutes left. Let's go back to the front because there's some questions that I skipped, and I think we have time for one or two more. This is a question about probiotics. So let's go into this. This is a difficult one, but I face it. So Japanese researchers recently published an article about two types of cholinergic urticaria: sweat allergy type or decreased sweating type. And in the decreased sweating type, they advise the use of intravenous corticosteroids a day for 3 days to treat the impaired sweat ducts. What are your thoughts about this? Yes, so to explain a little bit more what is meant by this. So the sweat allergy, the first type, comes from the observation that actually a portion of cholinergic urticaria patients react to their own sweat on a skin allergy test, which very good fits the autoreactivity concept, because the reason for this might be that indeed there is IgE, allergy antibodies, directed to sweat antigens and therefore causing cholinergic urticaria. The second type is difficult. This means that you basically have something like an autoinflammatory reaction in your sweat ducts, and that you have, well, impaired function of your sweat ducts, and by this releasing actually sweat into the skin, or components of the sweat into the skin, where the mast cells sit, and the mast cells react to this, and by this causing wheals and urticaria. Treating this by high doses, short-term high doses steroids may help, because it may reduce the inflammatory component which causes this problem. But by doing this, you are actually not get rid of the underlying cause, right? You're treating the inflammation just for a specific period as long as the cortisone works, but the reaction will come back at any time, probably. So my personal opinion on this is, yes, if you have very high dose, very high intense of disease, it could be worth to try, but it would not be my preferential treatment strategy, because you help urticaria by high cortisone doses anyways. There's no proof that this is specifically targeting the sweat glands, and for sure it's not a therapy which could be done for ages, and especially cholinergic urticaria also is a disease which you don't have for a couple of weeks, you have it for many years, and I believe that there will be better treatment strategies out there to treat this disease by high doses of corticosteroids. But this is my personal opinion, and what helps is good in a way, but of course this is causing side effects even if because you have to repeat, so you need to receive probably those cortisone shots every four weeks also. And I would rather try anti-IgE also in those cases because they may be equally effective. So we have come to the end of the webinar. I thank you all for sharing and joining, for your interest. And I would like to remind you that, as you know, there's International Urticaria Day tomorrow. This is the reason why we have this webinar today. You all know about the webpage because this is the reason why you joined this webinar probably. You have been to the webpage already. But please go to the events and go and do your urticaria activity score if you haven't done so. So please test how active your urticaria is. Regardless on what form or what type of urticaria you suffer from, there is the UAS, the Urticaria Activity Score test available on the webpage. Please do it, answer the easy questions, and post and share with other people on the world today, tomorrow, next week, whenever you have time, and bring the Urticaria Day to life. Thank you for your attention and have a good day.